should be something that pops up on your screen. So the iStar project is supported by a grant from the National Institute on Drug Abuse, and it's part of the larger NIH Helping to End Addiction Long Term, or the HEAL initiative. It's also one of several projects that comprise the Consortium on Addiction Recovery Science, or the COARS network. So this webinar is the fourth webinar in the iStar Researcher Training Series. And it's the third webinar that's geared specifically towards folks who would like to be studying recovery housing. So what does that mean? It means basically that we've developed webinars on topics that are particularly relevant to conducting research on recovery housing. And each webinar in this series will focus on a specific methodological aspect of research. And in addition to kind of providing a primer of sorts on the topic, we'll also highlight how recovery housing researchers have addressed this topic in their research. And the topic for this month's webinar is Principles of Community-Based Participatory Research. Next slide, please. So I'm Dr. Amy Maracle. I'm a research scientist in the Alcohol Research Group at the Public Health Institute. I co-lead the iStar project with Dr. Carmen Masson, who's a professor of psychiatry in the School of Medicine at the University of California, San Francisco. The team also includes some other amazing scientists, co-investigators Sarah Zemore and Lenny Jason, biostatisticians Meena Subbaraman and Liba Lee, communications specialist Diane Schmidt and Dustin Kebzu, and the team's project coordinator, Quinoja Capitani. Next slide, please. So the iStar project is guided by a 17-member advisory board comprised of a group of diverse leaders from across the country. And most advisory board members wear many different hats, but they represent generally recovery and recovery housing researchers and leaders in the movement, treatment providers and payers, national policy advocates, as well as other researchers and educators. We have some of our advisory board members likely in the audience, but I'm very excited to share that one of our presenters is a member of our advisory board. Next slide, please. So that's a little bit of background on the iStar project. But before I introduce today's webinar and webinar presenters, we'd like to do some quick polling to get a pulse on the virtual room here. And there are just 4 questions in this poll. The questions are: what best describes your field of study? At what stage are you in your studies in this field? How familiar are you with community-based participatory research principles and methods? And have you used community-based participatory methods in your research? So if we could launch the poll now, that would be perfect. And if you're familiar with Zoom polls, there are 4 questions, and to see all of the questions, you may have to slide that gray bar down to see all the all the questions and all the options for the poll. The poll will stay on your screen until you answer all 4 questions and submit your poll. And after you do that, we will look at the results. And I do want to thank you guys in advance for taking the time to answer the questions in this poll. It's really helpful for the presenters to have a sense of who's in the audience, so we can best tailor our presentation to you guys. But we also like to use the information in this poll so that in future webinars, we can also make sure that we're targeting the content to the people who are actually in attendance. And here are the results of the poll. Great. So I'm scrolling up. It looks like we have a good mix of folks here at the webinar. We have the largest number of folks from the health sciences field that I've seen thus far at 32%. But we also have folks in the field of psychology and social work, and folks who are identifying as something else. And if folks want to drop in kind of what their field of study is as something else, that would be helpful so that we can refine our polling options. So in terms of stage in folks' careers, so we have mostly early stage within the past 10 years of getting one's terminal degree, but we do have some more experienced researchers as well. In terms of familiarity, a good mix here. This is as close to a normal distribution as I've seen in a while. So the majority at kind of a 3 and a 1 to 5 scale with familiarity with CBPR. And a number of folks who have used CBPR in their research. Well, this is really encouraging, guys. I'm really excited to see who's in the audience today. I think there'll be something here for everyone. So for folks who may be less familiar with CBPR methods, you're definitely in the right place because we have experts here to talk about it. But if you're familiar with it but haven't used it in the context of recovery housing research, we also have folks who are presenting their recovery housing CBPR research. Next slide, please. So who are these presenters? Well, there's some real superstars in the field, and I'm super excited that they're here talking with us about this topic. We have Dr. Kathy Burlew and Dr. Leonard Jason as presenters today. So Dr. Burlew received a PhD in social psychology from the University of Michigan and later retrained in clinical psychology at Miami University in Ohio. As a professor emeritus of psychology at the University of Cincinnati, she continues to conduct research on HIV risk prevention and substance use treatment, especially for racial and ethnic minorities. She's co-authored or co-edited 70 books and journal articles, book chapters and journal articles. She's published several articles on cultural adaptation of evidence-based interventions and a series of articles on culturally appropriate research methods. In fact, she and her colleagues recently published an article illustrating their model called the Community Collaborative Cultural Adaptation, or the CCCA model, which provides a framework on how to implement academic and community partnerships to address health disparities. So we welcome you, Kathy. We'll also be hearing from Dr. Leonard Jason. Dr. Jason is a professor of psychology at DePaul University. He's edited or written 30 books and has published over 900 articles and over 100 book chapters. Dr. Jason has received over $47 million in federal research grants. Since the early 90s, he and his group at DePaul University have been studying the effectiveness of Oxford House recovery homes using multiple methods, as well as trying to understand the dynamic processes accounting for resident change. His scientific research has received views on ResearchGate from over 150,000 readers, and his research has been cited in over 1,700 articles. He co-writes a blog for Psychology Today, and a recent posting had over 180,000 views. I couldn't be more pleased with our presenters today. And with those introductions, I'm going to hand things off to Dr. Burlew.
Good afternoon, everyone, and thank you all for inviting me. If we could jump right into the next slide, where I wanted to just begin to get everybody on the same page. I'm glad to see that over half have already used CBPR in their research. So some of this will be a review for you. But community-based participatory research is an equitable, and I highlighted equitable, approach to research in which researchers, organizations, and community members collaborate on all aspects. I highlighted that as well because it's important, of a research project. CBPR empowers all stakeholders to offer their expertise and to partake in the decision-making process. And that for everyone partaking in the decision-making process, I wanted to emphasize. So on the next slide, I talk about the aim of CBPR, and it's to create, if we can move to the next slide, it's to create positive, transformative, and sustainable change together with, and I should highlight with, for, and in communities. So I've already mentioned one principle. There are research principles associated with CBPR, but not necessarily a specific set of research methods. As I already said, one of those principles is that it involves community members, researchers, and other stakeholders equitably. But along with that, it should combine a CBPR approach should combine knowledge and action to improve community health. It should avoid the perception of too many of us who are academicians, the perception that we have a monopoly on knowledge, and instead acknowledge and promote expertise and knowledge in the community. And it also should empower the community with tools to improve community health, even on their own after the research project is over. So on the next slide, I talk about some steps of in CBPR research. And I can't say enough about the need to build and maintain relationships with the community, doing something that some of us, at least in the past, called helicopter research, in which you enter, collect the data, and leave, will not work with a CBPR approach. Instead, a CBR approach, instead of a helicopter approach, requires the academic team to engage the community in the research project. The community works together with the researcher even to determine the research question. And it's not required that everyone work on every task, but the division of labor should be decided mutually. And the entire team of both community and academics should disseminate the findings together. So then why are we doing CBPR approach, CBPR research? What are the advantages? And I'll talk about that on the next slide, the advantages of a CBPR approach. Currently, both academia and the outside community have recognized the advantage of involving the community in much of social science research. And CBPR then addresses that need. So that's one advantage. But another advantage is that there's some evidence that psychological interventions are more effective when the target group is involved and able to provide a different type of expertise and a different perspective. Another advantage is that a CBPR approach has the potential to potentially shorten the research practice gap. Some people have argued that the time between when an intervention is developed and then determined to be effective, the time between that and when it actually reaches the community for implementation can be as much as 17 years. But CBPR, since the community is involved, shortens that gap. And also under advantages, there's evidence that the involvement of the community actually strengthens the community, empowers the community, because the community ends up with some tools that they can use after the project is over. My team likes the continuum on the next slide that categorizes the extent to which the community is engaged. You see, it goes from investigator-driven to community-driven. Notice the characteristics that Winkler, who authored this, assigns to the CBPR approach. in that approach, the community has in the CBPR approach, the community has a significant role in decision making, and the community holds some role in the implementation of the research project. Now, those steps, those types of research between investigator-driven and community-based, they occur in the community, but the community might have some minimal involvement, but the community typically has no role in decision making and maybe just a limited role in implementation. On the next slide, I just have a continuum of these same steps, from less community involvement to complete community involvement with community-based participatory research there. And I include it just because we'll refer to it later. So our team, on the next slide, has been interested in studying just how is the community involved when teams label their research as CBPR. And to do that, we conducted and published a PRISMA search of the literature with the aim of determining the roles that community members played in projects that are described in the literature as CBPR. We do quite a bit of sexual health work, so we chose sexual health interventions for doing this particular study. And you'll see on the next slide, we had a number of research questions. Who represents the community? Who is participating? Who's not participating? When community members are participating, just what is it that they're doing? Do community members have decision-making involvement? And does the team value both academic and community expertise? That was particularly hard to determine from the readings, but from the published articles. But if one great example is done by Joseph Gone at Harvard, who does research on developing interventions to address substance use for American Indian and Alaska Native men. And if you read his intervention, it's clear that it's not just based on something that Joseph Gone had learned in a traditional graduate program in his training, but included the cultural and spiritual traditions of the Blackfoot speaking nation that he was working with. They had some ideas about what should be included in a substance use intervention, and those are included. So that's a great example of a team valuing both academic and community expertise. But back to our study on the next slide, we actually decided on 3 different categories from the studies that we included in our search. In the first group that we'll call a level 1, the community partners primarily consisted of community agency reps. And these reps these community agency reps were typically staff rather than the target group. And they typically participated on advisory panels. And if we could go back to our continuum, because they were community agency reps and not participating largely, some people call this grass tops rather than grassroots participation. It seems to me that those studies kind of fell somewhere between community placed and community based, because they occurred in the community, but the need didn't actually come from the community. The need came from the research team, and there was minimal community participation with and the community had no actual decision-making role. the community had only a limited role in implementation. But back to our slide on the levels of community involvement. I don't know if we have to go back or forward on that to get back to that slide. We go back one slide, yes. Back one slide, yeah, right there. So then there was a second group, and in that second group, this was curious for us because these projects were described as CBPR, but the role of the community partners was never really even mentioned in the studies. There was just no detail provided. But in that third group, the target group members were involved throughout the project, and they had some clearly defined roles. A study by Rios Ellis is just one example of some of the studies that were in that third category. You could see in that study, they developed and pilot tested an intervention for reducing HIV risk in Latino substance using men. And if you look at how they were involved, the list of the ways in which they were involved, they participated in all of the activities from the development of the intervention to the final data analysis and interpretation. And that wasn't the only study in group 3, but all of the studies in group 3 had the same involvement of the target group throughout. And we thought that this group really met the CBR definition that Winkler had, because the target group had a significant role in decision making and also a significant role in implementation. So now if we just move forward, I just want to talk a little bit about our work. Move forward, yes, to that slide. Our work started out as investigator driven, I'm sorry to say. We do work in cultural adaptation, and I was involved as a co-investigator with the late Don Carlson in culturally adapting an intervention called Real Men Are Safe. We nicknamed it REMAS to be more appropriate for reducing sexual risk behaviors among Black male substance users. We had almost no involvement of the community in our cultural adaptation. Instead, we used academics and clinicians. So we had good results, good findings that the culturally adapted version was better, more effective than the generic version for Black male substance users. But when we took it to a conference, and I was a presenter that day, they liked the intervention, but they smacked our hands some for not including the community. So then we had an opportunity to culturally adapt the female version of that same intervention, which is called Safer Sex Skill Building. And we knew that we wanted more community involvement, and we landed on a technique that Gina Wingood, who does a lot of great work in cultural adaptation, developed. And this work is called, her work is called Adapt It. And there's one step in it that's called theater testing. So we did theater testing in which the community, the target group members, which were substance using women, participated in a group version of the intervention and then gave us feedback. But nevertheless, it felt like we still didn't, something was still missing from our intervention because from our process, because the women gave feedback, but they had no real decision making. And so that might be considered more like community placed or community based, but they weren't involved in the implementation, and they weren't involved in decision making. So finally, we had an opportunity. It felt like something was still missing. And so we had an opportunity to do a teen HIV intervention culturally adapted intervention. And this time, we actually developed an academic community research team that included members of the target group, staff residents, staff of the community, and adult residents in the community. And all of those members were involved from the beginning of the project. The results supported the effectiveness of the intervention. I won't have time to talk about that today, but I just want to share that to carry that out. And on the next slide, you'll see that our academic community research team. But to carry that out, we recruited girls to participate in a mock demonstration to give us feedback on the generic version and also on the first draft of the culturally adapted version. But even though they were just giving us feedback, the members of the research team were actively involved in all decision making. And so we felt like we had met the criteria for CBPR, which was because the community members of the research team were involved in decision making and in implementation. I wish I could say that a project like this was easy to implement. However, there were a number of challenges that I'll talk about on the next, that are mentioned on the next slide. One of the challenges was the inherent power difference between us, and if you could move to the next slide. There was we were never able to overcome the fact that because we controlled the payroll and because we controlled the funding in general, and because we had more education, there was that inherent power differential that's inconsistent with the CBPR approach. There were differing levels of responsibility and power, and the other challenges that were on there. And then there was the time of joining the community. I don't really like to think of it as a challenge, but it was time consuming. We involved ourselves in 6 or 7 activities in the community just to have a presence there. There were challenges within the academy as well. The implementation of the IRB procedures was a challenge on the next slide. The IRB wasn't always as flexible as we needed them to be. And just doing the city training sometimes was getting everybody through that was a challenge. And then there was the tenure issue. If you were on the tenure track, we didn't happen to be, just the time it takes within the academy. It's inconsistent with getting tenure, just the time that it takes to implement one of these projects. So on my last 2 slides, one of my last 2 slides, I share our model. We actually developed a model of community collaborative cultural adaptation in the process of doing this work. And it had preliminary steps, steps on the generic version of the intervention, steps on the adapted version, and then a pilot test. And the color coding shows what we did that involved the target group. And we're really proud of in this model is that the target group is involved throughout from the very beginning to actually if you look at the very last line, they even co-authored the publication with us, the community members of the research team. And I said at the very beginning that the academic and community researchers should publish together. And I would be remiss if I didn't just close by sharing this last slide, which the leadership of the CBPR research in the next slide has actually recently conducted a project called Engage for Equity. And it is a systematic investigation of 179 federally funded projects. and they write about these and their work on this in a special issue of the American Journal of Community Psychology. And if you're planning to do or continue to do CBPR work, I encourage you to look at this special issue because they learn quite a bit and it really advanced the field of CBPR research. And with that, I'll turn it over to Dr. Leonard to talk about CBPR and recovery housing.
Thank you so much, Dr. Berluth. That was a stimulating talk, and I can just say I always learn something from reading and hearing your work. To me, the long-term commitment and the power differentials are just so important for the lessons learned for all of us as we try to understand how we can research differently than we had in the past. I'm going to be talking about recovering housing, very specific example of Oxford House. I first want to tell you a little bit about what Oxford Houses are for those of you who don't know. Next slide. The Oxford House Network represents one model for helping reintegrate people back into communities. Oxford Houses provide affordable and safe housing for people recovering from substance use disorders. This self-help organization has grown from over one house to over 3,400 houses in the last few decades. Residents are rented, single-family homes for 6 to 12 individuals. They're completely self-governed with no professional staff. The slide shows a picture of an Oxford House and some of its members. This is not a group home, it's not a halfway house, and it's a family of members. And I say members rather than residents. It's a very different type structure. It's democratic, constantly evolving over the last 49 years. And as an example, MATs were often not something allowed in many recovery homes, but the Oxford House community has, for the last, I'd say 5 or 6 years, been very supportive of individuals on MATs to live in these Oxford houses. And that's one example of changes that have occurred as the members of the house develop the rules and develop the structures and decide what they're willing and what they're not willing to do. And MATs are medication-assisted therapies. Suboxone, methadone would be examples, and they can be used in Oxford houses across the country. Next slide. In 1991, I saw Paul Malloy on CBS's 60 Minutes talking about his unique creation. My intuition was that I could call him, though I'd never done anything like this before. I called Paul and said I was a community psychologist and wondered if anyone had done any evaluation of Oxford houses, and I said I would be happy to work with him. Out of that initial conversation grew a long-term collaborative partnership between a university-based research team at DePaul University and a grassroots community-based organization. Next slide. When Oxford House came to Illinois, one of the representatives named Bill Lee came to my research group and asked if he could be involved in the project with us. And as a team, we worked together. One of the things that happened was he was staying in a shelter, didn't have a lot of funds from the Oxford House organization, had all his materials and clothes stolen. And what we as a group did was there was a priest house at DePaul University, and we actually found a room for him there. He could stay for free. And we actually let him use one of our labs, so making phone calls. So because of that close collaboration, when he came to Illinois in the early 1990s to open up Oxford houses, when he opened up the first Oxford house, he called it the DePaul House. and it was in the DePaul community. Oxford House representatives from 10, 11 houses during that first couple of years, and my research team met for over a year and a half to get to know each other. We didn't do any specific research. We were just trying to have them get to know us and us to get to know them. We developed a questionnaire together, and we basically tried to understand some of the reasons people moved into Oxford House and what they were getting out of the Oxford houses. We had one of our people go to their houses and, with their permission, do some tape recordings so we could better understand what they were interested in. They sent someone from their network to our research meetings and tape recorded our research group so that they could bring it back to their group. So it's a mutual process of us getting to know them getting to know us right from the beginning of our collaboration. Next slide. After collecting pilot data, we spent years submitting and resubmitting a grant proposal to find federal support. The Oxford House organization wanted data to suggest whether it worked or not, but we were having difficulty getting funding for that. The NIH reviewers wanted us to conduct a randomized study, but our group said this was not possible, as each Oxford House votes on whether to allow new members to live in their family. So how could you do a randomized study? After 7 years of submitting grants that were not getting funded, Paul Malloy and I had a conversation where I basically said, we're probably not going to be able to get NIH funding for this proposal. Paul then said he would work with us to make it happen. And basically, we were able to get funding, do a randomized study, because we had the support of not only Paul Malloy, but also the Oxford House organization. So when we brought a person to a house and they weren't accepted, we could bring them to a second house. And eventually, everybody who we had in the study was able to get into one house or another. What I didn't know was that another research group had approached Paul Malloy a few years before I had, and basically said they wanted to do a randomized study with Oxford House. Paul said no to them, as he had not built up a supportive relationship of trust with them over the years, which our group had. Next slide. Real quickly, this is just a study that eventually emerged. First did one randomized study. Individuals completing substance use treatment were assigned to either an Oxford House or usual care and followed for 2 years. The Oxford House, compared to the usual care condition, had higher abstinence rates, 69% versus 35%, higher monthly income, $989 versus $440, and lower incarceration rates, 3% versus 9%. We next did another randomized study with criminally justice-involved individuals with substance use disorders. They were randomized either to an Oxford House therapeutic community or control condition. The cost-benefit analysis clearly indicated that there was a savings of over $12,700 for each person in the Oxford House, minus $3,000, $800 for the control condition, and a minus over $7,500 for therapeutic communities. So in these two studies, we actually were able to provide the Oxford House with information they needed to basically allow them to take next steps with the organization. And I might just add that I just came back from the annual Oxford House convention. And at this convention, I was told that by a person who raised their hand and asked us a question during one of our feedback sessions. We would go to the convention each year and tell them what we'd learned and ask them what they wanted us to learn and what they were interested in, questions they had for us. And one of the people, Paul Stevens, said that 20 years ago, when they went to meetings of substance use administrators for states and talked about Oxford House, they weren't getting a lot of attention or interest. After our studies came out, and they could actually show that Oxford houses worked, changed completely. And now they have contracts with most states And that's one of the reasons they've been able to expand the model as widely as they have to over 3,400 houses. Next slide. This study that we had published was basically approved by SAMHSA as an empirically validated program. Next slide. And the study got lots of publicity around the country. Next slide. At one of the conferences, when we were talking about some of the results of the study, someone came up to me, a resident, and said, "You see that woman over there?" And I said, "Yeah." He said, "Well, that's my girlfriend, and she has HIV. And I just want to let you know I would never have spoken to her because I was prejudiced and biased, and I didn't speak to people who were different than me, particularly someone who had other chronic illnesses. But I changed as a person, and that's what you need to study: tolerance, and what we changed as individuals. Yes, we stopped taking alcohol and drugs, but we need to know more about us as people who change fundamentally. So we took that observation back to our group, and Brad Olson was one of our team members, studied altruism. And over time, we found that residents of this communal living model showed significantly greater tolerance trajectories than those who were not provided it. And results supported the claim that residents of communal living settings have a superordinate goal of overcoming substance use problems. And that was actually very important for us to confirm that. The slide on the bottom are really social networks, and that's what we're currently studying with Oxford Houses. And as you can see on the left, the red are people who are using. This was a network at the beginning of a person's stay in an Oxford house. On the right is a social network of what happens 2 years later for that person. And you can see that there's very little red dots in that network because the people in their network have changed to non-using. And these are the type findings that we learned about because what the Oxford House people said is changing the persons, places, and things. Study that. And that's why we began to study social networks, because it's the person, places, and things that need to change for people to make this type of long-term recovery. Next slide. I'm going to kind of begin to close with this one story. Some communities oppose sharing their neighborhood with groups like Oxford Houses. For example, laws are passed that make it illegal for more than 5 unrelated people to live in a house. This deliberately targets Oxford Houses, which usually need 6 to 10 house members to make rent affordable. After release of our outcome study, I was called by a lawyer who asked if we could help him with the dispute involving the town trying to close down the local Oxford House by claiming that there could be no more than 5 unrelated individuals living in one house. We quickly looked into the National Oxford House data set, examined how the number of residents in Oxford House affected residents' individual outcomes. We found that larger house sizes of 8 to 10 residents corresponded with less criminal and aggressive behavior. These results were used in the court cases and others to successfully argue against closing Oxford Houses that had 6 or more unrelated individuals. Paul Malloy sent this note to me regarding one judicial case that resolved with data. I got a phone call from a lawyer at the beginning of the day, asked me about if I had any data. I sent him the article that was published. He got the article in the afternoon. The court case was closed. This is what Paul said to me in a note. The dispute has been going on for 6 years. The town will pay attorneys' fees, which are about $100,000, and a fine to the Department of Defense. The key is their decision appears to be your research showing that larger houses had better outcomes than the smaller ones. Thanks. Once again, reason and logic prevailed. Next slide. This is Paul Malloy. It started with listening to something on 60 Minutes. Over 30 years, we had a collaborative relationship. It's unfortunate that Paul has recently died. Kathleen Gibson has taken over as CEO, but the spirit has not changed. As a matter of fact, a couple of weeks ago at their annual convention, Kathleen came up to me and said, you know, there's a lot of college students that live in Oxford houses. We need to find out about how many. She asked me, can you devise some questions that we can put in our annual survey? So I went back to my team. We developed questions and sent it to her. So she'll be able to administer them to find out how many college students live in Oxford houses across the country. And this is just, again, one small example of a 30-year collaboration, getting to know each other, learning how to trust each other, each of us having opportunities to do things we couldn't do alone. And this collaboration was long-term and about us listening to what they wanted to find out and us collaborating. Thank you.
Wow. Well, thank you, Dr. Jason and Dr. Burlew. I gave you guys a really tall order to talk about CBPR within the context of a 1-hour webinar. And I love that you were able to cram so much in. This is really great information, but we couldn't possibly cover everything. So we have provided some resources for folks. Next slide, please. These resources include some textbooks and chapters on CBPR, some journal articles, and some other resources as well that may be helpful to you in your recovery housing research. We can also drop these resources into the chat with hyperlinks for folks if you want to access those. Next slide, please. And with the time remaining that we have left, I want to make sure that we open things up for discussion. So Drs. Burlew and Dr. Jason gave us a lot to think about. And I know that we have folks in the audience who have conducted CBPR. So I'm interested in any questions folks have, any thoughts or reflections. Feel free to drop them into the chat, or you can also raise your hand within Zoom and unmute yourself to ask a question. Any questions? I will lead off with one question. Dr. Burlew, I really liked the work that you did with the lit review and kind of parsing out what folks who are saying they did CBPR were actually doing. I'm wondering if there is any or has been any effort to look at kind of the level of community involvement and outcomes of research. I don't know how I would be thinking about outcomes of research as rather process or the outcomes of what's being studied. But I would think that the more community involvement would equal a better research study, but that would be just my hypothesis. Has anyone actually looked at that?
Yeah, so that special issue that I didn't get a chance to really describe very much, but they've started looking at those issues and not just in one specific study, but looking at it across 179 studies. They out of it, they've kind of developed a conceptual model that addresses some of the questions that you were just raising. And they've also looked at how context might influence outcomes. So yes, the leadership is has been looking at that. And when I say leadership, Wallerstein and Winkler are some of the leaders. I'm just someone trying to do work that they've trained us to do, but they've been doing this work for 20 or 30 years, just like Dr. Jason.
I love it. It's research about the research.
Yes.
Other folks, let me scan to see if I see any hands up.
I see something for me. can I read this one? This is for Dr.
Yes.
Berlew. As a graduate student, I'm trying to culturally adapt an instrument with my target population by getting feedback from community experts and community members across the country to get feedback for my instrument. I have not received any response back. I wonder if you have any tips for cultural adaptation process. You give me a chance just to say a bit more about our model. And if you send me, if you write to me, in our model, we actually talk about the steps that we think are important for cultural adaptation if you're involving the community. Now, that article might be on the list of resources. One of those articles might be on the list that Amy has on her resource list, but we have another article where we look specifically at the steps and the challenges in cultural adaptation. So do people have access to our emails, Amy?
That's a good question. So, Dr. Berlew, Dr.
I'll put it
Jason,
in
if
the
you don't
chat.
mind people contacting you, feel free to drop your contact information in the chat.
Right.
And while Dr. Berlew is doing that, we also have a couple more questions. So Jody asks, are there current models of inviting or incorporating clients into the development of programming, especially for mood programs? More than including people into the research process, what about a systems level structure for incorporating client experiences and perspectives?
So I'd be happy to speak of that. Casey Longan is an Oxford House member, and she has been developing kind of an intervention for her houses to basically reduce stigma on MATs, as well as to be able to use how to save people if they have, and in some ways, overdosed. And she has basically involved hundreds of people in this project, hundreds of Oxford houses, and has collected data. She has sent the data to our group. We have been analyzing it, and we have fed it back to her. And I talked to her at the recent Oxford House Convention, and Alcohol Treatment Quarterly has just published our first piece that talks about that effort. It originated from the Oxford House organization. It's involved hundreds of people. It's qualitative and quantitative data, all developed by Casey. And I may add that Casey was an Oxford House member who we employed at DePaul University a number of years ago. So she got really interested in research, and she worked with us, and now she's going back to the Oxford House organization and is taking some of those skills, collecting data, sharing it with us on MATs. So Alcohol Treatment Quarterly, the most recent issue, has our work in that area.
That's great. Thank you so much, Dr. Jason. And then we have another question from Madeline in the chat. Any advice for keeping community members engaged? It's easy to recruit and gather people to be involved in a process, but it's harder to retain community members month after month as they get pulled into other directions too.
I echo the difficulty in keeping community members engaged. As I said when I was speaking, that they have other things going on in their lives and oftentimes not able to participate even while the project is going on, but a long term as well. In our case, for our community members of the academic of the research team, we actually were able to pay them, and that kept them engaged some. I've seen some other models where community members actually were given the opportunity to take a university class on health disparities or community involvement, or something like that would give them a reason to stay around. But you certainly are have hit on a hard problem in doing this work, and that is keeping community members engaged.
I could just comment on that. If we switch it around, there are community organizations that have long lives, as Oxford House does. And maybe the other way of asking the question is, how do we keep researchers wanting to continue to work with them?
Yeah.
And basically partner with them over that period of time, because their movements continue. The questions they have continue to need to be answered. They need the expertise and collaborations with researchers. How do the researchers connect with something that's vital, sustaining, and basically will live on? And we need to kind of, in some ways, kind of see them as a driving force rather than ourselves.
Mm-hmm.
Thank you, Dr. Jason. I have, unfortunately, the unenviable task of cutting off discussion so that we can wrap up. We're almost at the top of the hour. But I think this has been a fabulous discussion, not only giving some really good, useful, concrete information, but this lovely example of CBPR over a course of a 30-year period, working with a community-based organization. It's just lovely. So we can go to the next slide. Just a heads up about kind of what's coming up with the iStar project. So we have 2 webinars next month. We have one in the provider series and as well as one in the researcher series. The provider series is on law and ethics and fiscal management as it pertains to recovery housing. And then the researcher webinar is on engaging recruitment engagement in tracking of marginally housed and criminal legal system involved research participants. So the provider webinar and the all audience webinars are the first Tuesday of the month. The researcher series is the 3rd Tuesday of the month. The same time, regardless of the topic, from 11 to 12 if you're on the West Coast, and from I guess that would be from 2 to 3 if you're on the East Coast. And you can find out more about our webinars as well as more about the iStar series on our webpage, which is pictured on the slide. You can also stay in touch with us through our newsletter, which you can sign up for on the website, and through our social media accounts. So next slide. Before I leave, I want to just remind folks who are registered for the 12 series training track for researchers that this webinar does count towards that 12 course series. If you attended live, we will track your attendance. Folks who watch all 12 webinars or participate in all 12 webinars can receive a certificate of completion for these webinars. And we can also list your name on the iStar website as someone who's completed this training. If you're not able to attend at a live webinar, no worries. We do post all of these webinars on our website, but we've also been developing a learning management system as part of our website, so that if you're registered for the series, we can track your attendance that way. It's also a little bit more interactive, a platform than just viewing the webinars through the recordings on the website. So with that, I think that we need to wrap up, but I really hope that we see you guys at another webinar down the road. Again, next month is recruitment and tracking of marginally housed and legal system involved participants. Thank you so much.